Well, good morning. Thank you for having me here. I think thanks goes to Susie and Brian for inviting me to be part of the National Myeloma family. I've been coming to these seminars for more than 10 years, and I think meeting you and talking to the expert made me a better myeloma doctor. Your journey is amazing. So I'm going to talk to you about frontline therapy in the management of multiple myeloma. So basically, you diagnose multiple myeloma. That means you have symptomatic. So basically, I think the first thing we have to do is to control your symptoms. If you have pain, we have to manage the pain. If you have high calcium, we have to manage that. And so obviously, we need to preserve your performance status and improve it if it's deteriorated. We need to rapidly control your disease and minimize treatment-related toxicity. And obviously, the goal is to keep people living 27 years and longer. So, so how we do it? I think the most important thing we have learned over the year is that the depth of response matter. Getting rid of 50% of the myeloma is not going to translate to a long-term survival. The deeper you get rid of myeloma, the longer you're going to live. So if you can see here, this graph is just showing us if you get a partial response, your myeloma is going to come back quickly. If you get a complete remission, yeah, I mean, that's great. But the deeper the response, the longer the patients are living and doing better. So we have been touching on minimal residual disease, and I think it's basically sensitive assays that will allow us to look instead of 200 cells in the bone marrow and say, okay, there are a couple myeloma cells left behind. Let's look at 10 million cells and find how many myeloma cells left behind. And the goal hopefully is none. And so why is MRD testing is important? Because we have learned that when you achieve a minimal residual disease undetected, your survival is better than when you still have minimal residual disease. So judge new therapy based on that, because I think that's been the newer therapy are better if they're producing more a number of patients with minimal residual disease. And basically, the other thing is that we always talked about high-risk disease. High-risk myeloma, what does that mean? You have a short remission and short survival. Well, if you don't have any bad cells left behind, you're going to do fine. So if you look at this graph, what it means here is that when you achieve minimal residual disease undetected, even in the setting of high-risk myeloma, you're going to do better than if some myeloma left behind. So again, making the case that achieving minimal residual disease, even in the setting of high-risk disease, improve the outcome. So this is the evolution. I mean, we all talk about how well we're doing with multiple myeloma. And I think you saw an example by Dr. Brian Dury earlier that some of the medications that are standard of the care, RVD, were in the rescue status. And now, why not some of these medication we're using in a rescue status? Why don't we use them up front if they are safe and effective? So it's a great, I mean, when we started working on multiple myeloma, you can see what we call new in the bottom. And now what we have is that we have a plethora of medications that I think with the right combination and the right setting, hopefully we can say we're going to cure myeloma. So how does your doctor decide what when you are newly diagnosed? We talked about that yesterday if you were here, this NCCN guideline. And the good news is there's a lot of options. The bad news is that how you're going to decide. So hopefully between you and your physician, you will figure out the regimen that is effective and safe for you. And so these are great to have options. So I think what's evolving is that combination therapy is very important. And I think I'll show you why that is. And I think today we have, these options that becoming more prevalent, available to you. The backbone of all the treatment has been the RVD regimen that Dr. Brian Dury showed you. and adding monoclonal antibody has improved the outcome. So I'm going to show you some of these examples. So this is the Dr. Duri's trial through the Southwest Oncology Group, and basically was, for a long time, what we had was Revlimid Dex, and that was the standard of care. Adding Velcade to it, or bortezomib, does it improve the outcome? And the answer is yes. If you look at the number of patients surviving without relapse, surviving period was superior with 3 drugs versus 2 drugs. So why just, in the old days, we say, okay, let's sequencing them. Now we say, let's combine drugs and show that we improve the outcome. And then the other trial was, do we always need the proteasome inhibitor, Velcade? So in the setting of newly diagnosed patient who's not transplant eligible, can we improve the outcome of patients over Revlimid Dex? And the answer was through this trial called the Maya trial, where they add a monoclonal antibody, daratumumab, to Revlimid Dex and try to see what is the outcome of these patients who do not want to transplant or eligible for transplant. These are usually complicated slide. It just show you the number of patients responding. And if you look at the overall response rate was superior, 92% versus 81%. But if you look at the depth of response, complete remissions was higher. That means you can get rid of more myeloma with these 3-drug regimen than the 2-drug regimen. So that's another option available to patient, is the combination of the monoclonal antibody daratumumab to Revlimid and Dex. And these are just showing you what is the, are we getting more toxicity when we add 3 drugs? And the answer is yes. You're going to have more drop in your white counts and maybe increase the risk of a pneumonia. So obviously that need to be monitored carefully and addressed appropriately. Now, is RVD a good option for a patient who wants to go to transplant? And there are a lot of trials and that. Did I do it or technical difficulty? Okay, here we go. So basically, actually using RVD as an induction treatment followed by transplant does provide good control of the disease. So that's another example there. And adding these combinations will produce more patients with minimal residual disease. So some of us still believe that for newly diagnosed patients, an induction therapy followed by transplant is a good option. But some people say maybe we can delay the transplant. So why this French study that I showed you earlier is very important, because in that study, what they did is they did maintenance for only 1 year. And what happened is that there are a lot of patients who did not have any therapy for some time. So what does that mean? Is that perhaps these patients who achieve a minimal residual disease and detected after an induction and transplant and maintenance for a year enjoyed a long-term survival. So that's an opportunity for us to start exploring MRD testing as a way to gauge the duration of therapy. And I think it's a challenging question, since MRD testing may reflect what's going on in that sample of the bone marrow. And Dr. Duri talked to you yesterday about newer technique for minimal residual testing, such as basically looking at mass spectrometry for residual disease testing the blood. So anyway, but I think what we need to do is really, does one size fit all? Should everybody get an induction, transplant, and maintenance forever? I think this exploration of these data suggests that we should start looking at way to say, okay, do not need to be on therapy forever. And I think a lot of us will like that if, obviously first you, the patient. So we need to design clinical trial that address that question. Now, we said RVD is a great thing. Can we improve on that? Revlimid, Velcade, Dex is a good induction treatment prior to transplant. So another trial done in the US looked at adding daratumumab to that regimen. This is a complicated design of the study, but basically you're getting an induction with 4 drugs versus 3 drugs. You're getting a transplant, and then you're getting consolidation with 4 drugs versus drugs, and then maintenance. So what does that mean to the patient when you do 4 drug induction treatment instead of 3? Well, the data suggests that the duration of response is much better, and living without relapse or things related to the disease was improved significantly. You can see the blue is on top, is the 4 drug regimen. So another indication that combination therapy will provide better control of the disease. And when they looked at minimal residual disease testing in that trial, and you heard the word is that it's not one time. You don't want to be looking at the bone marrow now and say MRD negative, this is great. You want to look at what we call sustained MRD negativity. And if you look in this trial, in lasting more than 6 months, MRD negativity was superior in the 4 drug regimen compared to the 3 drug regimen. And even at 12 months, the results also stayed impressive. You can see 44% versus 13%. So clearly, what's going on with 4 drug regimen is that you're getting deeper response, you're getting more patient in minimal residual disease and detected state, and that's had translated to improvement survival without relapse. So these are some of the summaries of upfront therapy, and significantly showing that the large number of patients well surviving better. So it is, I think, probably becoming the standard of care to consider 4 drug regimen as an induction treatment. So the other, I think, really intriguing things is the work that done by Luciano Costa and colleague at several academic centers around the country through what we call the master trial. So Luciano Costa is a nice guy, so I always call him Mastro Luciano, because I think this is a masterful work of my mind. Why? So what he was saying is that, okay, does everybody need to be on treatment forever? So, and the design of the trial was very clever. Basically, what they did is that they use 4 drug regimen: daratumumab, carfilzomib or Kyprolis, Revlimid, and Dex. And they use an induction combinations for 4 cycles. And then they did a stem cell transplant. After stem cell transplant, they checked for minimal residual disease. And if it was sustained negative, then they did, okay, this is MRD sure, and we're going to stop treatment. But if they were MRD positive, they did consolidation with 4 cycles. And again, they check for MRD negativity. And if it's negative, they stop. If it's still positive, they did another 4 cycle of consolidation. And after the second 4 cycle of consolidation, if there's still minimal residual disease, they put the patient on maintenance Revlimid. So this is an opportunity to say, okay, you got an induction, you got a transplant, and you have a sustained MRD negative, let's stop. So what did they find? Basically what he showed, that actually you can do that, even in patient with high-risk disease. If you have one high-risk feature, for example, 17p deletion or gain of 1q, basically, I'm sorry, yeah, 1q there. So these are on the bottom is the high-risk cytogenetic. They look at 1q gain, translocation 414, 1416. Basically, if you have one of them or 0, look at the curve at the top. It's quite flat. So that means a lot of patients have sustained a response for a long period of time. Unfortunately, this approach was not great for patients who have 2 or more high-risk cytogenetics. So that's a group of patients that need more attention and more exploration. But at least in patients with one high-risk cytogenetic, you can actually say maybe it's possible to do an induction and transplant. And if they are MRD negative at 2 subsequent testing, then you can stop. So that's their conclusion, I think, is an effective way of addressing standard risk myeloma and one high risk cytogenetic. Just to show you that there's another example of a monoclonal antibody, isatuximab, in combination with Revlimid or lenalidomide bortezomib dex as an induction treatment. And this is by the German group. And you can see the design, basically 4 drugs versus 3 drugs, stem cell transplant, and then maintenance with isatuximab, Revlimid versus Revlimid. And so we have some early results from this trial showing that the 4-drug regimen actually provide you with more patients with MRD negative. So that's a good news. And I think they showed that the number of patients achieving complete remissions and very good partial response is increasing when you use the 4-drug regimen versus 3-drug regimen. And they did further analysis just to show the safety profile, and it looks like, again, I think the neutropenia and pneumonia can be one of the. So really, what is my upfront therapy status conclusion is that it's really evolving. I mean, I think adding anti-CD38 antibody to VRD or KRD is feasible with limited incremental toxicity. Depth of response has improved, including more patients achieving MRD negativity. And MRD is becoming an important measure going forward. There's a trend to improvement in what we call living without relapse. We can overcome high-risk cytogenetic in some patients. One high-risk cytogenetic, not a big deal when you use those 4-drug combinations. I think the challenge, patient who has couple, what we call double hit or more high-risk feature. So is stem cell transplant important? A lot of the trial I showed you does include stem cell transplant. So maybe there's still a role for that. So I think this is an example of the future. I think, again, Luciano Costa, Maestro Costa is checking this in the Master 2 trial, which is, it's the dream trial. What is the dream? The dream is to really, can we cure multiple myeloma? And here is, I showed you that the things that always on the, were the drugs that listed on the right for rescue, now becoming, probably part of the upfront therapy. So what he's trying to look and say, okay, if you get a quadruplet induction and you get a stem cell transplant and you're not in remission, still have minimal residual disease, can we improve on the outcome? Do we use a monoclonal antibody, or can we bring some of these new immunotherapy? You're going to hear more about it later. But these are good drugs. They're producing amazing results in heavily pretreated patients. So why can't we use them as a consolidation for the high-risk patients and see if we can improve the outcome? So I really think this is challenging the dogma today that we maybe can control the disease but not cure it, but bringing some of these novel therapy up front should hopefully lead to a lasting remission in a lot of patients. So we are after you, myeloma. So I'm here with 3 myeloma patients riding bicycles and making sure that myeloma become history. Thank you.
You can actually stay at the podium for the Q&A, okay? Oh, you're gonna, okay. And then if we could just have our Darryl, if you come up as well, yeah. You know about frontline therapy. Yeah, yeah. Yeah. Yeah, so you can stand right there. Okay. And yeah. So Where's Robin? We're going to. All right, you're going to coordinate a Q&A?
Right. So this is our opportunity again to ask questions. Oh, look at the hands. Hands are going. Tom, I saw yours first.
Okay. Hello.
There's some of us that are have never been MRD negative and seem to be lasting anyway, but kind of just coasting along. What do you recommend in those cases? Just keep treating it and keeping it down, or what?
I'll let Rafat answer first. So should you, if you're doing well, should you stay on the maintenance, or as we talked about a bit yesterday,
Yeah,
at some point,
boat, yeah.
right? So
okay.
what do you think?
So actually, to be honest with you, will be the
Well,
best.
that's good. It's
Yeah.
always good. Yeah, be honest.
So the best thing is to know what is the minimal residual disease. And that's what I think we need to explore that better. So obviously, if myeloma within each patient is not all behave the same way. So you have what we call different clone, so that's we call it clonal heterogeneity. That it's like a family of 10 kids. They don't all behave the same. I mean, one kid, you look them in the eye and they sit still. The other one, you may not need to be too PC, and you may have to use things that will end you in the prison. So basically, you have to be aggressive with aggressive clone. And so the question is, do we know when we have minimal residual disease, do we have an indolent clone, the one that sort of smolder for a long time and behave like monoclonal gammopathy if undetermined significant? We don't have that technique. So I would say that if you've been doing well, you actually declared yourself biologically. You have a clone that is indolent and you're doing very well. Now, all these things I talk about is really addressing upfront treatment and looking at patients, after an initial treatment. And it's great because unless I know what the minimal residual disease is like, aggressive or not aggressive, today it makes sense to try to get the best regimen that will lead to more patients with MRD negativity. But, it doesn't mean I have to change anything for you right now.
So I'll make a brief comment and then we can ask our panel. But basically, my inclination is to keep patients who are doing well, even if they're MRD negative, is to keep them on the maintenance. For example, if they're on Revlimid, if they're tolerating it, I would adjust the dose. But keep them on it. And there are several reasons for that. Many times a patient who has gotten to that point, it's been tough to get there. And if they would ever relapse, they would have problems getting re-induced and going through therapy that could have risk of infection or other kinds of problems. So my inclination is to try to, if it can be tolerated, is to keep the maintenance going and adjust the dose and try to keep the patient in remission without giving any chance for relapse. But
I think I would divide my comments in 2 parts. First is when you
yeah. So first of all, we didn't introduce Dr. A.G. Chari, who has until recently been working in New York. Has recently come to California. Welcome to California. He's now working at UCSF up in San Francisco alongside Dr. Tom Martin and the team there. And so welcome to our meeting today.
Thank you. Yeah, it's great. My first California meeting, so happy. So I think first comment I would say is that when the FDA was asked about MRD as an endpoint clinical trials, they said we're not ready. And why is that? And it's because there's different ways of MRD, low and PR. There's different depths. Are you checking for 1 in 100,000, 1 in a million, 1 in 10 million? Is it one time or is it persistent? Is there extramedullary, meaning is there a myeloma outside of the bone marrow? So there's a lot of caveats to the test. And up till now, most of the studies have shown that if you're MRD negative, you're going to do better than those who are positive. But there's a difference between that, which is a prognostic statement, to a predictive statement, which means, so does it help to convert one to the other? And we lack data. You may think, well, isn't that intuitive? And that second part of my response would be, you can't have a blanket statement. It depends on the patient. So if this is a frail elderly patient, they don't care about MRD. because we just want them to have a good quality of life. If the patient has high-risk disease, then you care more about MRD. They have high-risk genetic changes if they have myeloma coming out of the marrow. And lastly, how did you get to that MRD? What treatments did you get? If that was with minimal therapy and it's weak, maybe. But if this was at a lot of therapy, so I think it's hard to give a blanket statement. But I agree, like if you're doing well and it's a low-risk patient, it could be an MGUS clone. And so that's the danger of using these tests, because if we drive everybody to MRD negativity with every tool we have, and it was just a little bit of MGUS that's remaining, that's not going to necessarily translate into better outcomes for the patient. It may just cause more harm. Conversely, if it's a very high-risk patient, really do want to get rid of that MRD clone. So I think we're in a bit of a data gap. So I would just kind of use the extremes of MRD right now.
Thank you for that. So other comments? All right, the people are hesitant to jump in there. All right.
Before we go on, Dr. Dury, I just wanted to make sure everyone here, especially the panel, remembers that we're live streaming. I don't know if we said good morning to the folks we're live streaming to today. So hello, everyone.
Good morning, live streamer, or good afternoon. I don't know where you might be. Yes.
Of us found that we had the multiple myeloma because of a bone problem.
Yeah.
What can you tell us in generalities or other about bone regrowth, bone regeneration following successful transplant and treatment and maintenance chemo?
We touched on that a little bit yesterday in terms of the length of the treatment, right? Now you took Zometa or Iridia presumably for bone treatment? No, Zometa, yeah. So the big question is, you know.
She can tell
So
you.
I think we have an expert here among us. Yes, Nupur has worked the most on bone.
I
So-
think everybody's worked on bone, but you're right. Bone disease almost pathognomic of myeloma. So most patients with multiple myeloma will have bone disease at the outset, and that's largely because myeloma cells like going to bone. And if you think about it simplistically, it is the myeloma bone disease, kind of an form of osteoporosis. What we've gotten right now is with all of the treatment, anti-myeloma treatments, and Dr. Dury mentioned this yesterday, 10 and 15 years back, we had a lot more complications with bone. We see less of that. Doesn't mean we're not seeing it at all, but anti-myeloma therapy is so good that it's able to control bone disease quite well. We also recommend using the bone-targeted agents like zoledronic as Zometa, pomegranate, or Xgeva, and those should be used. As far as your question about bone healing, if you actually, so with myeloma, you can get those lytic lesions with holes in the bones. Don't heal those completely, but what ends up happening is thickening of bones around that lytic lesion. So we call that sclerosis, and that then prevents you from other complications like fractures, etc. So it doesn't heal completely, and which is why when you have disease and when you keep getting scans, you're still going to have those lesions there, but doesn't mean that you're actually progressing.
Thank you so much. Yeah, so I think that's good detail. So maybe we'll move into the speed round now. We'll have short questions and short answers. Yeah.
Move the mic. Dr. Raji, could you move the mic a little closer so we can hear you better? Maybe all the speakers. We want to hear the good stuff. Thank you.
Hey, you talk a lot about having a transplant or slide. I had the induction therapy. I did not get a transplant. I'm MRD negative. I'm on no maintenance therapy.
Okay.
Do you think I would have benefited from having the transplant, or would you recommend I still get it or just write it out?
We're moving into the easy questions now. Yes. So who wants to start with? Rafat?
I did answer it yesterday, so I just want to make sure I told her the right answer. So I want to hear your comment.
I think it goes back a little bit to the previous thing too, right? So it depends on the patient. So younger, better risk patients, that's more encouraging, but also how long has it been off therapy? Because that's another important point. We saw from the master study that when you discontinue therapy in MRD negative patients, high risk patients relapse earlier, not as high risk relapse later, and then the low risk patients even later. So MRD negative is not unlike other cancers, it really matters about the patient profile. So it's not a test that you can just apply across the board. So I think it's great to be off therapy. I think we need to do more of that in myeloma, and not everybody needs to be on therapy for the rest of their lives. However, we need to do it in a thoughtful fashion, and the way we historically have done that with is large randomized studies. So, but as an individual patient, you can always deviate from the study based on your own tolerance and risk profile.
Right.
And the fact that you're doing as well as you're doing, I think that's great. The one thing we've learned is, we've done these randomized studies comparing transplant versus no transplant. And if you look at all patients in totality, yes, there is a benefit for transplant in all of those studies, but I don't think we can say that individually. And there is data to show that if you get to MRD negativity, and whichever way you get to that, your outcomes are pretty similar. So you're doing great. Congratulations.
So the only comment I would make is that we have this trend of moving the treatments from the right to the left. And so stem cell transplant is a relic of our chemotherapy past. And it could be that one of those immune therapies like CAR T therapy could be the wave of the future and could move in and substitute for that high dose melphalan and the things related to that. And obviously with the advantage of CAR T therapy is that mostly we would be fine to follow off treatment after CAR T. I think that would probably be reasonable. But I think that either way, my feeling is that there are so many backup options. It's tremendous to be off therapy, right? This is good. And this is the comment that we get from patients with CAR T therapy. They're so pleased to finally be off therapy, right? There's some people here in the room that could advocate that. And so we have so many therapies. If you're monitored closely, there's no reason that we can't jump in with one of our newer combinations and really do a fantastic job. It used to be that we always said that your first therapy was your best therapy, but that may no longer be the case. Some of these backup therapies are pretty amazing, as I showed on that one slide. If you need something, it could be amazing. All right. In the meantime, enjoy.
Hello, good morning to all of you. I'd like to
Well, that's
see,
good. Yeah, all of us. Yeah.
I'd like to see if you can guide us in we're at the point where now that I'm reading about what Dr. Rafat was explaining about MRD. Robert has had induction therapy and he is in a stringent complete response. He had DRD, so didn't need the Velcade, so it was only 3 lines. And a lot of centers, myeloma centers here in California, do not perform MRD testing.
Right.
So it took a lot of homework on my part and a lot of persistence to finally get one of the treatment centers here to get MRD testing when we did the bone marrow. So when we did that, I had to order the test, and we've gone through, it's been for over a year, we've been back and forth with clonoSEQ, and they're saying that they are not able to test for MRD because they needed the original sample when he was first diagnosed to find out, that that's their baseline. But in this slide here, it says that using flow symmetry sensitive at 10⁻⁵, it can be done anytime on bone marrow samples and does not require the patient to have the sequence at diagnosis.
Right.
So is clonoSEQ MRD testing the next gen that does require it, or where should we go at this point to find out? Because it's a very important, Robert did not get transplant, but it's a
Right.
very important tool to help us decide. And we
Right.
know it's not an endpoint, but
Right.
it's a very important tool to help us decide what's next.
Right, right. So maybe I can give the capsule summary on this. So what you're referring to initially is next generation sequencing. So when you do MRD testing using the genetic test, you need to have the genetics from the beginning. So you do need that baseline sample to guide you to look for any myeloma that is left. Using this flow test that I was talking about yesterday, next generation flow, you can do that at any time because myeloma is myeloma and you can just look to see if it's there or not. That is the test that will be FDA approved within the next 6-9 months. All right. And then it will be possible, and I would assume reimbursable to get that done. But the points that AJ mentioned are so important is that it all needs to be standardized. There's so many variables. And so I don't think that we want to be pushing and saying that people should get it done because there's so many things that could influence if it ends up being positive or negative on how deep it is. And even when you get that result and it says MRD negative, you know, what are you going to do about it? We don't know fully. So
What about the flow? But you were there.
oh yeah, I mean, okay. So the next capsule summary is that within trials, I mean, we're pushing to have MRD using NGS or flow approved to assess the outcome within clinical trials. So within clinical trials, the treatment is standardized, the testing is standardized, and so then it is a very, very good guide. And it can tell you if one treatment is better than another. But that's different than getting a test and then making a personal decision on an individual basis. Yeah.
The one thing we didn't talk about is I think no one here is going to be disappointed if we stop doing bone marrows, right? And hopefully in the future, we can get to blood-based assays. And that's really important because if you're doing a bone marrow aspirate and you just are taking out blood and you're not getting those juicy fat particles, an MRD negative is meaningless. You're basically testing the blood.
Right.
So if we could avoid that, the painful procedure and do blood, and you can monitor blood every month, right, with all the other labs. I think that's the future. It's just another constraint of a bone marrow. Let's try to move past it. And there are exciting mass spec and other technologies, but again, still need a lot of validation.
Right, right. That's what I was talking about yesterday. You weren't here, but where that very sensitive NGF can be used in the blood. And so I think we're pointing towards using blood to do very sensitive MRD testing and also to have mass spec available with the basic mass spec, the Extent, which is going to be approved soon, and then with a backup of a very sensitive mass spec. So what I was saying is that within the next year, we will have very sensitive blood testing, which hopefully will be available and reimbursable that will help you out, okay? And in
Dr.
the
Derek?
meantime, we'll see if we can give you proper guidance about what to do about it.
Dr. Dury, I was just thinking, part of your question was about you needed that first bone marrow, right? So with next generation flow, you don't need that first bone marrow, right? So that,
If you're doing next generation flow
Right.
in the bone marrow, you need to have a good sample, as you just heard. We don't want to be just testing blood, which is going to be negative. And so actually I mentioned yesterday that there will be guidelines, and we're going to use a method that was developed by Dr. Sigurdur Christensen from Iceland, actually, where he has developed a method for measuring hemodilution, where he can take the sample and then checking what's in there, he can tell, oh, this is just a diluted blood sample, you know. And so then you can set that aside, and that could be done right away. And you could say, if you really, really do want to get this information, you're going to have to do another bone marrow.
we have one more question from Mr. in the back.
Yeah, thank you. Yelich in his comments mentioned personalized or patient-driven as one of the things IMF is working on them in the
Right.
future. And I know that IMF has just,
And he's sitting right behind you, by the way, just to be aware.
I'm throwing him up on the stage as well. I know that the IMF has just entered into an agreement with a data company And there are a couple of other organizations that we won't mention here that have
Right.
things called Cure Cloud and Cure Hub. And so we haven't discussed patient-driven.
Right.
Well, we have to some degree, but using data, I'm wondering if any of your organizations are doing anything. And I know it's complicated because we have clones and subclones and
Right.
disease changes. But I wonder if any of you could speak to that, what your organizations are doing in that respect, either data-driven or otherwise.
Right. The first comment that I would make, brief, is that, these treatments that were developed, that are being developed, they work basically for everyone. Now, they're personalized in the sense that we look at high risk, we look at standard risk, but we don't look at, Jim who's 50, or, we don't get to that like really personal level. We're looking broadly at a patient who might have myeloma outside of the bone marrow, extramedullary disease. We look at that group of patients and see what treatment works for them. And so for that type of a situation, you don't need so much of that personal information. You just need broadly what myeloma features would drive the decision process. But I don't know.
So, so I think the future is going to be clinical trials is going to prove a theory. 4 drugs better than 3 drugs. But if you look at clinical trials, really do not reflect the every patient we see in the clinic. So I think the way to overcome is by looking at real world data. But that's the definition of real world data is you need to be careful with. Because what happened is that you just select a group of patients and you analyze them and they say, these were not on the clinical trials. And we looked at their data and that's the real world data. Real world data will be you extracting all the data on all myeloma patients from electronic medical record, and you put them in a database and you curate it in a way that is meaningful. You retrieve the data and you find out how did the patients with these characteristics is doing. That's the future of real world data. ASH, American Society of Hematology, trying to develop the myeloma hub and things like that. And will be great when you combine that with looking, when you do a bone marrow biopsy at diagnosis, you take the bone marrow, and that's what we're doing. We have the Indiana Myeloma Registry. We look at the CD138, that's the myeloma compartment positive, and the CD138 negative, that's the microenvironment where the myeloma cells are living, and we sequence that. And the goal is to combine the clinical feature over the journey of the patient with the genetic information about the myeloma, about the microenvironment, and then you can understand that. But one center, one group is not going to be enough. The larger the number, the more patients we have into this database, I think we're going to be able to understand the disease better. So I think that's the future of real world data.
So comments?
I'll just make 3 quick points. First is, we've heard like when to treat myeloma, how many drugs to use, whether or not to transplant, whether or not to do maintenance. Wouldn't it be nice to have personalized medicine rather than everybody getting this cookbook approach? And I've always had lymphoma envy. Our colleagues who treat lymphoma, the pathologists look under the microscope and say, this type of lymphoma is called indolent. This is moderate. This is highly aggressive. Each of those patient groups gets completely different treatment. In myeloma, the pathologists can't help us. They say, okay, this looks cancerous, but they don't tell us what kind of myeloma it is because you can't tell visually. That said, there are already data sets. So at our previous institution, Sinai, we actually, all the physicians had a shared data list in the electronic medical record of patients who had been cured. We heard about it, but we have had probably anywhere from 5 to 10% of patients who have had myeloma, have stopped therapy, and have remained relapse free. We need to study those
for
patients.
14%.
I think, depending on the data set. The IMWG, that 15% for people who had transplant. Right. So I think depending on the data set, so we need to study that. Who are these patients that we're curing and how do we pull them out of the treat everybody forever model? And lastly, we have come close to this. Our closest example of personalized medicine in myeloma is 11-14 myeloma, where those patients who get venetoclax have exquisite sensitivity, even more than daratumumab. And yet that's unique to that one subset. So it's the first example of if you have 11-14 myeloma, you should get venetoclax. We can discuss when might be the earliest, but they, I would say as early as first relapse, but Maybe even we should be using it in initial therapy, but that's our closest low hanging fruit. But we need more of that, as you're astutely saying. We need probably informatics to integrate not just genetics, because genetics is not enough. And we need probably the bone marrow microenvironment, the patient features, extramedullary, MRD, all of that needs to be integrated and coming up with a
Right.
recipe for an individual.
Yeah, the final caution I would give is that real world data is really very difficult. I mean, it doesn't account for the fact that, you know, after COVID, you were so sick, you decided to go on vacation to Italy for 2 months, and then you skipped your treatment. And then when you came back, there was a delay in getting the medicine from your pharmacy. And so actually the outcome for that round of therapy, you know, is not correct. You know, so you need to be very cautious about using and interpreting real world data. And that's one advantage of trials, is where it's standardized. Okay.
Okay,
Is that it?
was the round. Thank you very much. And if Dr. Raji could stay up.
Thank you, guys.